guest to grace the stage. Time to introduce the eminent resource persons whose presence truly enriches this international seminar, Arogya Sangam. Our first esteemed resource person is Dr. Subarna Roy, Director and Scientist, GICMR, National Institute of Traditional Medicine. A distinguished researcher and visionary leader, Dr. Roy has made remarkable contributions in integrating traditional medicine with modern scientific understanding. Next distinguished guest is Dr. Ramesh Srivastava, Sir, Senior Principal Scientist, CSIR CIMAP, Lucknow. His inspiring work in medicinal and aromatic plants has played a vital role in advancing the frontiers of natural product research. We are also honored to have with us Dr. Kishore Ramakrishnan, Sir, Professor and Head of Department, Integrative Medicine, NIMHANS, National Institute of Medical Health and Neurosciences, Bengaluru. A leading voice in the field of integrative healthcare, he continues to bridge the wisdom of Ayurveda with the precision of modern medicine. Now I would like to take this opportunity to invite our respected Dr. Rinjinji Krishna Sir to kindly introduce our esteemed guest person, Dr. Subarna Roy, and to invite to deliver his presentation.
Good afternoon, one and all. I welcome you all to the post-lunch session. It is an honor and privilege that I have got this opportunity to welcome our esteemed guest, Dr. Subarna Roy, Director, ICMR National Institute of Traditional Medicine, Director in charge, ICMR Regional Medical Research Center Northeast, Founding Scientist in charge of Model Rural Health Research Unit, Raichur, Outstanding Professor, Faculty of Medical Research, Academy of Science and Innovation Research, India. A microbiologist by education, a molecular epidemiologist by training, and a field worker by experience, Dr. Subarna Roy likes to be introduced as an ordinary citizen of India. He has worked in interfaces of health research connecting basic sciences with applied research, field epidemiology with laboratory, traditional knowledge with big data biology, traditional medicine with modern medicine, and field research with health systems. Dr. Roy's mission is to erase boundaries and take health research to new frontiers by cooperation, coordination, and collaboration for collective health and wellness. He has published more than 150 papers, filed 7 patents, guided 14 researchers to the award of PhD degree so far. His contribution during the Great Asian Tsunami in Car Nicobar Island in His contribution during the Great Asian Tsunami in Car Nicobar Island in 2004 helped prevent outbreaks of infectious diseases in the hundreds of displaced indigenous tribes. He identified iodine deficiency disorders as a major health issue plaguing 8 districts of North Karnataka and flagged the re-emergence of diphtheria in the state. Dr. Roy has worked extensively with the state governments to establish a model rural health research unit in the aspirational district of Raichur and is on the verge of establishing another in Korlim, North Goa. ICMR has given Dr. Roy the additional charge of the Director of ICMR Regional Medical Research Center for Northeast Assam, which has 5 rural research units in 5 of the 7 northeastern states. Dr. Subarna Roy is a recipient of the prestigious Major General Sahib Singh Sokhe Award, the highest honor for contribution to infectious diseases in ICMR, the S.S. Mishra Memorial Award from the National Academy of Medical Sciences, New Delhi, and the Karnataka State KSTA Fellowship. Dr. Roy is also a member of the Executive Committee of ICMR, New Delhi. It is an honor to have Sir with us today. I welcome you, Sir, to address the gathering. Sir, over to you.
Good afternoon once again, and thank you for the elaborate introduction. As usual, it is very difficult to have attention after lunch, but I would try to do my best, and I would urge the young students to kind of understand, and even if you have questions, please do let me know, because these are very important things which we are talking about, and perhaps will be determining the course of the treatment that we are going to have in the next few decades in our country. Is it working? Oh. Can we go back? Yeah. So I'll be talking on the strategic framework and scope of integrative medicine. And before we go into integrative medicine, I would just like to give the WHO definition of traditional medicine, which is very broad. So you need not go into details. It is also being revised and it will be changed. And most importantly, what I wanted to show you in this slide is that we have one hand the conventional medicine or the modern medicine, and on the other hand we have traditional medicine. Now Ayush system is within the traditional medicine paradigm, and there are quite a number of practices which are beyond the codified system of Ayurveda, Siddha, Unani, Soha, Rigpa, Yoga, and homeopathy, which are practiced by communities, sometimes tribal communities, which are practiced by folk healers and Vaidyas in different parts of the country, in whatever name they're called. And what happens is that they are often considered illegal in terms of law. These practices are sometimes guided by superstition laws and all in different states. So their practice is actually not recognized. So the contents of my presentation I'm just given here. So I'll talk about the alternative, complementary, and integrative medicines. I'll be talking about the definitions of integrative medicine, its principles and objectives, its components, our own experience only in the integrative health aspect research, and the existing guidelines and framework, and the scope for integrative medicine in India, and the challenges and the way forward. This is a definition given by ChatGPT, because I said in the morning that we still don't have accepted definition of integrative medicine. So it says integrative medicine is an emerging field that combines conventional medical practices with complementary and alternative therapies to provide a comprehensive approach to healthcare. Now again, ChatGPT, like any other AI, if you just tweak the query, then little bit changes will come in its definition. Basically, integrative medicine is a comprehensive, holistic approach to healthcare that combines conventional medical practices with complementary and alternative therapies. I have put asterisks on complementary and alternative because you all know what we take as a reference, whether that is alternative or that was the original. So we know what is the problem with. So how do we differentiate between alternative, complementary, and integrative medicine? Or we sometimes use them as synonyms, but that is not the case. In the morning, sir was talking about how integrative medicine is. I think he has put the nail, hit the nail on its head. So we have a misconception about the mixopathy and then the various practices of alternative and complementary. This figure actually gives you a very comprehensive look at what integrative medicine is. So alternative is when we use one against the other, irrespective of the system. Complementary is when you are using something and you are adding on something else to that, but the synergy is not very well defined in this particular case. And integrative medicine is something where actually it is intrinsically connected. So the the contemporary medicine system knows what is happening through the traditional system, and the traditional system also knows what is happening in the contemporary system. So it's a both a kind of a consensus treatment that is being given. So the principles are: first is the emphasis on the patient centricity. It considers individual preference. Its focus is on prevention and well-being, treatment of the person as a whole, and the root cause. It incorporates mind, body, and spirit connection, and its objective is to seek what we say achieve optimal health and well-being. The optimal is very important here. Now, there are several modalities. We know we are talking about Ayurveda, Siddha, Unani, homeopathy, the material sciences, as well as you have some spiritual things as well inside it, including some of the meditation and other aspects as well. The benefits and efficacy is the practice evidence, clinical studies, and research supporting the effectiveness for specific health conditions. For example, in pain management, chronic illnesses, mental health, some of these issues where we still do not have usable remedy in even conventional modern medicines. So as I said, I will be dealing with this in 5 components: the policy, regulation, research, education, and practice. As far as policy is concerned, we are broadly guided by the National Health Policy of 2017, which talks about enabling pluralism by access to Ayush care based on documented and validated local, home, and community practices, and then to meet national health goals and objectives through integrative practices, and even preventive and promotive health with Ayush practices. So there are various efforts of the government which are linked to these policies. As far as regulation is concerned, we have almost none. Integrative health. We have started to do some exercises which we could, for example, the Ayush ICMR collaboration has resulted in this document this year, which is the ethical requirement for research in integrative medicine. This is an effort which we tried to do. We tried to make a standalone document on research ethics in integrative health. I and Dr. Gautam, the head of integrative health in AIIMS New Delhi, were the co-chairs of that committee. And we had deliberations for over 1 year, but more problems than solutions came. So there are so many issues that needed to be addressed, so which we thought would take a much long time. So what we decided is that we will make a very small one, and we just made a 2-pager addendum to the ICMR ethics guidelines that is already in place. So that solved most of the problem that we had at hand. So this has come out as an addendum to it. So it's a 2-pager. Talks about the how the ethics committees will be and what comprises integrative health. But this is mostly research which is conducted on traditional medicine in modern or conventional medicine setups. So in modern medicine hospitals, the biggest problem that we were having is that most of the modern medicine hospitals were not taking up research in integrative health because they are saying it is a Ayush intervention and all, we will not be able to take, and all this we do not have a provision for doing research on that. So to address that, this was done. Now, as far as research is concerned, most of you know is that the pyramid of evidence, where the case reports, case series form the basis of the very ground level of evidence, and then we design different research studies, and then at the top, as far as modern medicine is concerned, is the randomized controlled trial, and then again we do meta-analysis of those trials, systematic reviews, and then we come to the conclusion of what is happening for those kind of interventions. Unfortunately, research in integrative health is very, very limited across the world. In India, it is more so. Why? Because most of the time, the authentic information that we take is from PubMed. And many of the journals where most of this research gets published also, even if it is done, are not indexed in PubMed. Some of them are in predatory journals. So therefore, even good work sometimes goes waste because they are not taken into consideration because they are not listed in the proper databases which actually are accessible and can be trusted. So this is one problem that we have, and we all need to address this issue. The WHO, the PAHO, has certain evidence maps they have generated. So this slide was presented in the last meeting of the international, the one which was conducted by GCTM in Ahmedabad, so in Gandhinagar. So there are some of the efforts being made across the world to put these evidence maps together. As far as practice is concerned, again, this is limited to certain hospitals and certain small groups, including the NIMHANS. Dr. Kishore has been working on integrative health for a very long time. So the Medanta Hospital, Amrita Hospital, these are all few hospitals who have their integrative health research, integrative health practice. But then it has not expanded much to other hospitals and other settings as well. So that is again one area which actually needs to be addressed. As far as education is concerned, in the morning, Madam has given an elaborate presentation on that, so I'm not touching it. But the Ministry of Ayush is trying its best to see that the knowledge in the Indian systems of medicine actually goes to the MBBS students and vice versa. So that efforts are being done at multiple forums. Our institute at Belgaum in Karnataka, it is working on this connect between modern medicine and traditional medicine, between Ayush and the traditional medicine, and the Ayush and ICMR. So now, 2 years ago, there has been a MOA signed between the Ministry of Ayush and the ICMR, where ICMR is providing a 6-point action plan with Ayush. So to carry out research in some of the leads that Ayush has, I will come to them later on, perhaps I will go through. So I showed this slide. So what we do is that we try to take the best of both worlds and put them together, whichever works, and then mostly it is targeted for public health outcomes. This is the validation cycle that, I'm sorry, the slide has gone completely haywire, perhaps because of the fonts. But what we do is that we first validate the traditional medicine that is being used. So it starts with the community or in the clinic where it is used. If it is a Ayush formulation, so it will be used in the clinics. If it is from the traditional healers, then it will be used in the community. We have specialists who are ethnobotanists. We have specialists from the community medicine. So they go to this field and they do observational studies. They do situation analysis. They do studies on their primary use, the safety of those drugs that are being used, who are the people who are actually practicing, what is their background, if they're practicing it for profit or they're practicing it as a pastime or their traditional knowledge, what is the satisfaction level of the people who are taking treatment, whether they're coming first time to them or their treatment in modern medicine has failed and then they're coming. So these are kind of information that is collected, and then we try to see if it apparently is working. And if that treatment is apparently working, and if the traditional healer is willing to share his practice, the formulations that he is using, then we take it into the laboratory and do a series of laboratory tests. Now, mind you, these practitioners, if they are not from Ayush, they are from the traditional side, they will not be able to even define what is the ailment that they are treating. Somebody will say, I'm treating, say, knee pain. They will not say whether it is arthritis or anything else. Even if it is arthritis, it is osteoarthritis or it is rheumatoid arthritis. If it is they're treating jaundice, they will not be able to say whether it is obstructive jaundice or infectious jaundice. Even if it is infectious jaundice, what kind of hepatitis, or hepatitis A, E, or B. So these are kind of things that we need to do at our level. So we take them, we do complete pharmacognostic studies, we do ethnomedicinal studies, the identification of the genuinity of the plant, vouchering them, giving accession numbers, storing them, and then the phytochemical analysis and complete profiling, their chemical genetic profiling. We do a safety study in small animals as a rule of thumb. And then we do these days a lot of bioinformatics studies using computational biology. We do modeling with all the phytoconstituents which are already reported from this particular plant or formulations. And then we try to dog them with some of the disease targets that we get from modern medicine. The pathways that are already reported to be responsible for that particular ailment or the disease or that condition, we generally try to identify them and then do in silico studies to identify which are the likely compounds which are present in that formulations which are acting and in what manner. That helps us design the in vitro studies in the laboratory to see whether they are working or not through in vitro methods. So those are kind of things that we do. If it is infectious disease, if it is on some infection, then we have a very strong microbiology laboratory. We have a virology laboratory. So we do test them in vitro in those labs as well. And we try to do a molecular biological studies of the mechanism of action of these particular formulations. Not always easy to do, and sometimes it doesn't give good results, but we still try to attempt to do that. And then we take them into the efficacy studies in animal models. The preclinical studies we do in our animal house, we have various models, including the zebrafish and the C. elegans models, which are much more ethical than taking into larger animals. And then once the animal studies are completed, then we go back to the community or to the hospitals where we do clinical trials. So some are even randomized controlled trials, and many of them happen in communities, and some of them happen in hospitals as well. I will give you some examples. So that is how we complete the validation cycle. So we are mostly people from either modern science, modern medicine background or basic scientists like me. We have even domain specialists in Ayurveda, which are given by the Department of Ayush of the Government of Karnataka. We have Siddha specialists, which are given through SFC by the Ministry of Ayush through the National Institute of Siddha, Chennai. So we have people from all domains coming together and doing one research to validate particularly one medicine or one treatment for a particular disease. So as I said, that we are trying to develop a fourth tier of healthcare. You know, our health system is so overwhelmed with people, and the affluent people with small ailment will go to a tertiary care center, whereas the poorer people with major ailments will not be able to afford to go to even a secondary healthcare system. So that is how things happen. So we are trying to build a pre-primary tier using this alternative and complementary and now integrative health, so that people do not fall ill in first place, or even if they fall ill, then they are able to manage to a certain extent, which is possible. So we tend to utilize the Arogya Mandirs and other available facilities that we already have in our country. So basically our institute is connecting modern healthcare with Ayush and Ayush with folk medicine. So we are basically the bridge. We also have model rural health research units across the country. Our institute is looking after one established one in Raichur, which is an aspirational district. These are dedicated for rural health. So any of these interventions that work good are generally tried in this kind of settings where we have people who are from the lower socioeconomic status and who will be actually much more benefited than the other people. So we have that setting as well. So some of the trials go on in this kind of settings. We also initially, when we started, as I said, that when the documentation of these practices happen in communities, that becomes the starting point. Initially we had a database CD of more than 500 medicinal plants that are used for various conditions in the Western Ghats. Now it is in the form of a freely accessible web resource at nitmmedplantsdb.in. You can see in your mobiles and you can log into it, and you can search on the disease that is being treated and the plants that are being used. So you can search on plants or even on diseases. So you will get the list, you will get references, whatever has been done. So from there, you can actually start doing further research. So that is a good resource for the students and the faculty as well. We also have a database of the practitioners of North Karnataka, the traditional healers. Because say, for example, I want to get a treatment for cancer. So who are the people who are treating cancers in that region? So from this, I will come to know who are the people who are treating, and then I can approach them for further research. But this is not in public domain. As I said, these are all illegal practices in terms of law. So they are kept with us. So anybody who is interested in research, we generally direct them to these resources. Now, the validation cycle that I have showed to you, there are a few of those leads that we got directly from these traditional healers. They have completed the entire validation cycle, and presently randomized control trials are going on. The one is on arthritis. So this is something which actually we had taken the help of Dr. Chopra for a very long time. And we have actually done the clinical trial as well in BMK Ayurveda College. I think Dr. Giridhar was also a team member in that particular work. And we got good results. And now a multicentric clinical trial is going on in D.Y. Patil Medical College, Mumbai, in Dinant Mangeshkar Hospital, Pune, and in Jain Medical College, Wardha. So this actually helped in reduction of the OMEX score, the reduction in pain, a decreased inflammation, and in the walking speed. And good thing is that if we apply that topical formulation on the knee for 7 days, you need not have to apply for 1 month. So it will reduce your dependence on NSAIDs as well. So this clinical trial is ongoing. Similarly, another thing that we started from scratch is on diabetic foot ulcers. Surangi, the Mamia suriga. So the essential oil from Mamia suriga, we found it very good in animal models. And now this is also undergoing randomized control trials in D.Y. Patil, Mumbai, in Jain Medical College in Belgaum, and in Jain Medical College in Wardha. Now, those are two examples that I said we ourselves completed that cycle. Now what we are doing, this takes a lot of time. It is not possible for a small institute like us with only a few researchers to do everything. So nowadays what we are doing, we are taking some of the leads even from Ministry of Ayush. So Ayush Ministry had given us one of the lead for dengue, which we had done clinical trial in BMK Ayurveda College, where Dr. Giridhar was one of the co-investigators. And we carried out and we gave that data to the Ministry of Ayush. They have not yet published the results yet, perhaps because there was not much of a difference between the control group and the intervention group. We just completed another study for the Ministry of Ayush, which is called Ayush GGIMS, and this was again done in BMK Ayurveda College in Belgaum, and the study has just been completed and the data analysis is ongoing as of now. Now ICMR has joined hands with the Ministry of Ayush. Ministry of Ayush has given ICMR the Punarnavadi Mandura and Drakshavalaya as the lead in management of anemias. And this study ICMR is doing on 8 institutes across the country. We are also one of the institutes, and this study is ongoing. We are in the middle of this study, so recruitments are ongoing, and we expect the results to come by next year. So we will have very robust evidence of Punarnavadi Mandura and Drakshavalaya. We are also doing certain studies in other combinations along with IFA with Drakshavalaya, and these are studies which are done by ICMR NITM, And again, most of them are in the rural community settings like Raichur, which is an aspirational district, and where many people are presenting with low hemoglobin levels. I'm just going through some of the studies. Another study was an intervention of iron-rich snack developed by the Transdisciplinary University in Bangalore. So we are testing it for how it is improving the hemoglobin levels in certain people. So that also is, it just completed, I think last week, and the data analysis is ongoing. So we will also get to know about it. One problem that we are facing with this is the compliance, because it is a methi chip and it is a little karwa in test. So many people are not having full compliance to what is desired. Similarly, another study is ongoing. Again, this is a RCT going on in Irsha Pune, in CCRS Bangalore, Cary, and in KLE Hospital in Belgaum. It is on sustained weight loss through Triphala. Triphala, we know, is known for its ability to reduce weight, but we are actually trying to see how is it able to sustain that weight loss. Mostly what happens once we leave any weight loss drug, then again regaining of weight happens. But there is a hypothesis that it actually increases the brown adipocytes and reduces the white adipocytes. So based on that concept, this study is being started. So we are starting the recruitment next month. So these are about the various trials or the integrative health trials that we are doing and coordinating. I showed just a few of them, but essentially what I wanted to tell you is that it is not that only we are doing the trial for drugs that have been validated by us. Wherever there is a gap, we are trying to do. Even there might be certain drugs which have undergone clinical trials and are having good effects, but they may be lacking the molecular mechanism of action. So we chip in with that. So it is like doing your fill in the blanks, which people used to give in our childhood. So it is more of those gaps. Wherever are the gaps, we are trying to fill in with whatever is possible. So that is how we are trying to do. And everything, if you see, is done in partnerships, because we can't just work alone. It has to be done in collaborative manner. The amount of research that are doable is enormous, and therefore we need to multiply forces. One of the study I just wanted to show, again, will be a good candidate. We are going to start a clinical trial on that, is on cancers. We all know that soft tissue cancers, doxorubicin is the most preferred drug that is used, but it has tremendous cardiotoxicity. So with chemotherapy, a lot of toxicities happen in the heart, liver, and kidney. But once co-administered with cocoa extracts, then the cardiotoxicity, the hepatotoxicity, and the renal toxicity is reduced drastically. So we have done it in animal models, and we have published them as well in good journals. Now we are presently starting a clinical trial on that. But cocoa is a very well-loved and accepted substance. So you can just recommend, I generally recommend any of our known friends and relatives who are undergoing cancer chemotherapy, just do take dark chocolates and try to see if you get benefit over your chemotherapy. So this is where integrative health has again a lot of scope. We also do systematic data, systematic reviews and meta-analysis. Meta-analysis, or the umbrella meta-analysis we did on the safety and efficacy of the carica leaf extract, the papaya juice for management of dengue. What we found is that actually, if you administer carica juice extracts through the capsule, then there is a minimum of 16,000 increase in the platelet count, and the hospital stay reduces by 2 days. So this is what all the clinical trials have shown, and combined together effect is that. So we are going to publish this very shortly. Then again, we are doing, we have this one we have already published on various interventions on iron deficiency anemias that have been done across the country. These are all not what we have done. These are so what already has been done. We are trying to analyze them and try to put them in perspective so that a policy can be taken on this by the government. I'll skip some of the other leads that we have. Just basically wanted to tell you that there are many things that can be done. One of the important things that I'll be telling you is that now we are doing a lot of, or we are starting to do a lot of integrative health research. What about herb-drug interactions? This is something which is very less appreciated, but then very common. I said in the morning, with diabetes, we do take metformin and many other anti-diabetic drugs, and along with that, we take a lot of herbal preparations, which any friends, relatives, even our practitioners suggest. There are quite a number of reports where actually they act in synergy. Sometimes it may result in hypoglycemia, so that is a risk. Sometimes it may be contrary, so it can actually reduce the effect of the other. So we have to be very careful in taking those drugs. So that is what we tried to make a database of what already has been published for diabetes, arthritis, and gastrointestinal disorders, because these are the very common ones that we take medicines from both sides. What we did is that we have taken published literature and put the data. We have also taken a predicted likelihood of having interactions through computational biology. That also has been put. But then this database is still not published, or it is not in public domain, because both the secretaries, the Secretary Department of Health Research, RDG, and Dr. Koteja, the Ayush Secretary, is not very comfortable in putting it in public domain as of now, because there may be misuse of this as well. So, but at some point, these are kind of things that are going to come in. So the scope of integrative health research, as I said, is that Ayush and ICMR has now partnered together, and they are establishing the integrative clinics in all the Ayush across the country. Our institute is training all the AIMS in actually how to conduct research in integrative medicine on these integrative health clinics. AIMS Delhi is a very well-known and very reputed one, so they are into it. But most of the newer AIMS, including here in Gorakhpur, so they have people coming in, but then to put it actually in perspective of integrative health, we are trying our best to put them in. Yeah. And then we have the Ayush ICMR trials. As I said, the trial on iron deficiency anemia. So that is ongoing, and the next one is coming on arthritis as well. So like that, new trials are going to come both from Ayush and ICMR together jointly. Our institute also has a clinical trial network where we had asked for expression of interest from any hospital settings who are willing to do research in integrative health. We have had them listed in our database. So whenever we are having some projects, we are engaging with them and telling them, for example, the anti-cancer activity. So if some cancer hospitals are willing, we generally ask them whether you want to come into this network and want to do this research with us. So that is how we are doing. So this is again an opportunity that exists. And then there are others as well, other than ICMR, other than Ayush, and even private settings also, they are doing a lot of integrative medicine together. Mostly the research in traditional medicines are guided by the Ayush documents. I'm not going to details, but then again, there are issues sometimes with the design, because RCTs are not always able to answer certain questions which we have in traditional systems. So the black box design, the reverse pharmacology design, some kind of issues will come with most of the design. So we need to actually work on newer designs as well for taking Ayush research and integrative health research further. I'm not going into details of this. Reverse pharmacology, you all know. So these are basically the designs. There are problems with placebo in Ayush, because many of them are not even materialistic. Sometimes it is both together, diet, so many factors come into being. And then again, evaluation of efficacy also becomes a problem at times. One of the things that we generally do in randomized control trial is that, say I take a drug and I have say a diarrhea with that drug, and I write it as a ADR, adverse drug reaction. But then a traditional healer, if I go and say that I am having this, then he will be very happy. He said, you are having, that means it is working. So whatever is kind of taken as adverse in modern medicine sometimes is actually taken as a positive from traditional side. So these are kind of practical things that need to be taken into consideration. Ethics, I already said. There are very many other challenges and controversies that exist, that there is no clear-cut definition of any regulatory authority for the purpose of granting permissions or regulating the clinical trials. There is no definition of a new drug with reference to ASU and AH drugs. Conventional medicinal practitioners, again, cannot prescribe ASU drugs. Minuscule WHO GMP compliant ASU and AH manufacturing units. Lack of formally or institutionally trained ASU and AH researchers. Availability of this training, again, I would like to say that our institute is providing training to Ayush professionals across the country. Initially, we have started with Ayurveda and Siddha. The first batch is being trained now. We are handholding them for 2 years in their own practice and research. The first batch we are doing along with the National Institute of Epidemiology in Chennai. And we are also trying to come up with a course on integrative health research online. So it will be a MOOC course as well. Again, there are other issues like identification of the proper botanical because of naming issues and many other issues. Now, basically, to summarize, that we have a fragmented integrative health landscape. The fragmentation is the hierarchy of knowledge. Who decides what counts as valid knowledge? If I have said that RCT is the ultimate in evidence, am I the right person to tell that? So these are questions that come. Who will decide what is the benchmark? Reductionist science has become an arbitrator of all truth, and perhaps the deepest and hardest of the upstream problem. Institutional fragmentation. I said that we all do research in very small fragments everywhere. There is workman fragmentation. So that is again a problem. Evidence fragmentation. I said that in our literatures, we don't have the proper, when we want to do a systematic review, we don't have enough studies to fit into the criteria. So that becomes a problem. And then in the morning, I said our on ground actually integration exists. We all take integrative medicine. It is based in our roots in civilizational foundation. We already live and seek integration. So if I am sick, I will not say I will take only modern medicine or this. Whatever gives me, reduces my problem at the minimum cost, I will take. So that is what we already have. Now the policy and all is actually happening now with the Arogya Mandis coming in and with over 2.5 to 3 million community health workers and nutrition workforce. Things are trying to get integrated. Now these are all courtesy Dr. Vishwajit Kumar of the Community Empowerment Lab in Lucknow, who actually summarized this just last week. We had a big international conference in Hyderabad, and I'm taking the recommendations from him in this last 2 slides. And then there is a lot of opportunity. I will end with this as a design of an integrated care model with protocols and pathways to clearly define the roles and responsibilities. And we need to implement in implementation research. Once we know this works, so it has to be implemented. And we have to have evidence-based models, context of the sensitive of that particular place, region, and the population. And we also need to train human resources. We also have to scale up whatever is working well. So with this, I would like to end and once again thank the organizers for giving this opportunity. It's a vast subject, but I tried to put it in as short as I could. Thank you.
Thank you so much, sir. A visionary academic and an inspiring mentor, Dr. Manoranjan Sahu, sir, has dedicated his life in nurturing excellence in Ayurveda. His profound insights continue to elevate every forum he leads. Dr. Sahu has contributed immensely through his research, teaching, and administrative expertise. His guidance has always inspired students and professionals alike to pursue knowledge.
Thank you for sharing this session. And there won't be any question and answer. Question and answer.
Thank you so much, sir.
The question and
If anyone asks to like to ask some questions, you can. Yes, sir.
yes.
अभी हमारे सामने बहुत ही इम्पोर्टेंट टॉक आपने दिया और बहुत ही कॉम्प्रिहेंसिव और इंफॉर्मेटिव। एक चीज मैं कहना चाहूंगा कि इट इज माय पर्सनल परसेप्शन, माई सेल्फ प्रोफेसर जीएस तोमर, आई एम रिटायर्ड प्रोफेसर एंड प्रिंसिपल ऑफ गवर्नमेंट कॉलेज। One thing is very important while we are talking about the integration. Each and every system of medicine has got its own strengths and limitations. We cannot criticize any system. As far as the integration is concerned, merely evaluation of a single plant is not Ayurveda. Ayurveda has got the vast scope regarding the different preparations available in the Ayurvedic market. Ras, Purna, Viri, Vipak, Prabhav and Karma. These are the common criteria for the assessment of pharmacodynamics and pharmacokinetics of the drug. To compare the Ayurvedic drugs on modern lines is not the proper criteria to criticize the Ayurvedic drugs overall. As far as the clinical evaluation of the Ayurvedic system of medicine is concerned, our council, CCRAS, is doing a wonderful job. During COVID pandemic, it was criticized that the Ayurvedic path cannot be used because we are not having any evidence-based studies. My dear friends, I would like to narrate this important thing. Evidence is a very narrow thing. Ayurvedic things are narrated on the four principles: Aptopadesh, Pratyaksha, Anuman and Yukti. That's why we cannot discard those principles. Empirical studies. Parinam kya hua? Ayush path was used by the maximum population and they have been benefited by this particular thing. तो जो स्टडीज हो रही हैं उसको ओवरऑल सिंगल प्लांट स्टडीज कैन नॉट गिव द प्रॉपर रिजल्ट्स और प्रॉपर evaluation of the Ayurvedic system of medicine. Thank you very much.
No question. Any question for me?
एक चीज सप्लीमेंट करना चाहता
हाँ सर.
I feel there are a lot of talks. I mean, as a ICMR director, he has given a. कोई बात नहीं. It's all right. He has really integrated systems of medicine. मैं एक example quote करता हूँ जो probably one of the best integration carried out by ICMR. You see, I don't know what you have mentioned or not. That is a clinical trial, multi-center clinical trial on Char Sutra therapy. That is one of the best example, you see, which exists and probably the bread and butter of many Ayurvedic practitioners is scientifically validated through multi-centric institutions, rather, I will say. They are the premier institution of our countries who's validated that an Ayurvedic therapy is valuable in treating a most difficult surgical conditions, that is a anal fistula, and especially in related to the complex anal fistula. That is one which I want to supplement with your talk.
It is even better than modern medicine.
Right, it is.
Even our disease.
Right. It is that the very correctly mentioned that there are several publications are available that the therapy is superior to the conventional surgical treatment which is available. So that is one of the best example, you see, when science integrates that improve in health services.
So I worked for several years at the Foundation for the Revitalization of Local Health Traditions, FRLHT.
and they have a wonderful plant database, and they get information from both the
Traditional healers.
canonical and the non, what you say, the traditions without literature. Many of those traditional practitioners had wonderful treatments on offer, which needed real deep validation to be considered acceptable. Could you make some more comments on that?
You are absolutely right, sir. FRLHT is actually TDU now, the Transdisciplinary University. Yeah. So during FRLHT, we have actually adopted the validation or the documentation from the FRLHT. And it is along with them, we did the database that I showed. So it is actually a continuation of that same exercise. And the FRLHT database, everything is not in public domain, but ours, this part is completely in public domain so that people can use it. And for the information, it is our institute's mission and vision was actually prepared under the chairmanship of the head of TDU, Dr. Darshan Shankarji. And so it is, we are so close to them, it is very difficult for us to even tell that was different. And also it is a kind of a continuum. And as I said, that we all work together. So, so yes, we do our part. Our strength is more with the modern health system. So we are the connect, as I said. So we are kind of bridging it. So the traditional knowledge, the documentation that has been done, wonderful documentation. And some of them are actually, even we did a study on the on these practitioners who actually are treating. What we found is that around 50% of them actually appear to have a lot of merit in what they are trying. Remaining 50% may not be that dependable, but around 50% is actually very good. Again, when we did some research, we found that many of these practices that these traditional healers do are actually the same kind of plants and the same kind of things which are used even in Ayurveda or in Siddha. But then they are much more refined than the traditional practitioners, how they use. So the Ayurveda, Siddha, they have become much more professional and much more refined than the crude system which these traditional healers use.
I'd like to produce one more comment on that. There was one. Good. One more comment. There was one plant that was talked about which was used against malaria by one of the people in, I think, Guwahati.
Guwahati.
It could have been. It was somewhere in North India. And there were two versions of this plant, but you couldn't tell them apart by looking at them. But some wise old lady could say, oh, this one works, but this particular plant won't work. But once that old lady was not available, you couldn't reliably use the plant. And these are extraordinary details.
Yeah, you have pointed out a very important problems with dealing with medicinal plants. We have not worked on the malaria plant, but we did work on Gymnema sylvestri, Madhunashini, Gurmar. That you will find in almost every anti-diabetic formulation that is available in the market. And the active principles are known, gymnemic acid and diacyl gymnemagenin. We did a study on this Gurmar, which are available. Now, this grows in the Western Ghats and in Eastern Himalayas. We collected 117 accessions from different locations in Western Ghats and in Eastern Himalayas. And we found that at the same time collected plants, there is a variation of gymnemagenin and gymnemic acid by 35 times. So if you take a particular plant from one where there is 35 times more of active principles and one plant where it is much less by 35 times. How do we expect the same efficacy? So these batch to batch variations, the variations between the plants, their age and all is very difficult sometimes to understand, because our market is also not that matured. It is only harvesting from the wild that people use. But if there are methods in which we have the same explant and grow them for the pharmaceutical industry, so we will have uniformity and some standards have to be made. So it will come in a matured market, but perhaps not at this stage. We don't have it. So that is what I thought I will share with you.
Thank you so much, sir. Now I would like to request Dr. Manoranjan Sahu, sir, to felicitate Dr. Subarnan Roy, sir. Now I would like to invite our respected Dr. Ranjan, sir, to kindly introduce our next distinguished guest, Dr. Ramesh Srivastava, sir.
Now it's time for our next presentation, and for that, it's an honor and my privilege to welcome Dr. Ramesh Kumar Srivastava, sir. He's a senior principal scientist and head of business development group at CSIR CMAP, Lucknow, and a professor at ACSIR. With over 25 years of experience in medicinal and aromatic plants, he has led more than 28 national and international projects worth 80 crore, focusing on farmer income enhancement, rural entrepreneurship, and sustainable bioresource utilization. A former deputy manager in the private sector and assistant director at the Fragrance and Flavor Development Center, he has also served as a UNIDO consultant in Egypt. Dr. Srivastava has published a book, 11 technical bulletins, 2 patents, 89 research papers, and several book chapters, and was elected Fellow of the National Academy of Sciences, India in 2022. He is also a visiting professor at Mahayogi Gorakhnath University, Gorakhpur. It's an honor to have you, sir, with us today. I welcome you, sir, to address the gathering. Over to you, sir.
Thank you. So first of all, I would like to thank organizers of this seminar to invite me to discuss about the plants, especially our plants. We are focusing on medicinal and aromatic plants, which is the sole raw material of Ayurveda or any system of medicine. So it's very difficult to have the genuine, authentic plants for making their medicine, making their extract, making their churna. So first we start. Oh.
My presentation.
So my today topic is sustainable use of medicinal and aromatic plants in Ayurveda and wellness of for human being. So I belongs to CSIR CMAP. CMAP is Central Institute of Medicinal Aromatic Plants. It's situated at Lucknow. We are especially working on development of plants and its value addition. So this institute was established in 1957, and we are working on agriculture, biology. In biology, we are breeding, we are developing number of medicinal plants, aromatic plants, and their popularization among the farmers for sustained supply, for sustained cultivation, for supply of raw material to the industry, then extracting their chemical profiles, all phytomolecules, and drug development, even bioprospecting the uses of their medicinal aromatic plants. So when we are developing new varieties, we need multi-locational trials because we are working for all over India. So we have 4 centers, 2 in Uttarakhand and 2 in South India for multi-locational trials. So we have these centers for research and development. So while developing, why we develop medicinal aromatic plants? Because number of wild, most of the medicinal plants are collected from the wild sources. So most of the plants, in case of aromatic plants, about 80% plants are domesticated or cultivated by the farmers for extraction of their essential oil. In case of medicinal plants, most of the plants are collected from the wild sources. So when we collect from the wild sources, we have to follow the proper collection pattern, SOPs. Otherwise, we have to cultivate the genuine variety, genuine species to find better results while making our drugs. So that one issue is quality issue. When we collect any plants, their age, their species are not defined. So we have to cultivate. Then variety, whatever variety we collect, so it's again difficult to identify which one is better, which one is not better, because our earlier speaker is talking about the efficacy of the plants. So provide this stable and defined assured quality plant material to the industries, because when industry is talking about development of any drugs or any phytomolecules, they have to have sure about the sustained availability of their raw material. Then again, wild collection, stopped wild collection. We have to stop the wild collection because number of plants comes under the red data book for as endangered or extinct. Okay, so if any farmer cultivate the improved varieties of medicinal aromatic plant, their income will be enhanced. Okay, so again the livelihood opportunity can be created in the rural areas, and the country perspective, number of medicinal plants we are importing from small countries, Nepal, Indonesia, Sri Lanka, even China. So we have to think about the import substitution and export earning and conserving our genetic resources. So these are the basic criteria for the development of the our medicinal and aromatic plants. So we have developed more than 200 varieties of medicinal aromatic plants, and most of the varieties are industrially used and cultivated by the farmers, and they are generating higher income in comparison to traditional crops like Acarus calmes, aloe vera, Andrographis paniculata, Artemisia annua. Sir, you are talking about anti-malarial drug. So we have developed four varieties in Artemisia annua, and we have transferred this seeds along with the extraction technology to 7 multinational companies like Cadila, Themis, Ipca Laboratories. They are making the cerebellar malarial drugs out of Artemisia annua. Then Asparagus racemosus, Bacopa moneri. So these are the chamomilla. So these are the plants we have developed and popularized among the farmers for cultivation. Then Comifera, because the Comifera is only available in Rajasthan. Once we cut the plant is going to be extinct. So we have to developed one variety. We have developed Marusudha. So they are having very good chemical components. The Curcuma longa, we have developed one variety that is Simpitambar. Simpitambar is having more than 12% total curcuminide, not curcumin, total curcuminide. Okay. Then Glycyrrhaza glabra, Mukna. So these are the varieties developed for the cultivation of the farmers and provide the sustainability of raw material to the industry. In case of aromatic plants, we have developed 6 varieties in mentha, that is peppermint. India is the largest producer and exporter of mint oil due to these varieties. More than 4 lakhs farmers are adopted this cultivation, and we are exporting more than 30,000 ton of oil to more than 145 countries due to these varieties. Then Simbopogan flex versus lemongrass. We have recently we are importing these lemongrass oil from the small countries, but now India is the largest producer and exporter of lemongrass oil also. Then vetiver khas. Khas is utilizing in number of Ayurveda preparations, even in flavors also. So we have developed 2 varieties, and these varieties are quite popular among the farmers. And these are the other varieties in basil. We have developed 12 varieties in 12 species. We have about 54 different chemotypes of ocimum. So we have very good, and we have analyzed whole genome of basil and analyzed all the genetic responsibilities of we have developed Roja Damascena Pacholi. So these are the varieties we have developed and popularized among the farmers. So these are some pictorials of our mint. Then Sim Sanjeevani we have developed in Artemisia annua. Then Khas Krishna in lemongrass, Sim Saumya in Ocimum basilicum, and Sim Ayu in Ocimum sanctum. Then Posita in Ashwagandha. We have developed 7 varieties in Ashwagandha. Recently we have developed one variety Posita. Posita is quite common among the farmers. If we talk about success stories, so the mint is having very good success story. We are transforming India into importer country to the largest producer and exporter in the world since last 30 years. And we are producing more than 90% of total world production, and Uttar Pradesh is producing more than 80% of the total world consumption. Okay, so and we are earning more than 4,000 crore revenue yearly in our GDP. So these are the good example. Like lemongrass, 3 times our honorable Prime Minister has talked about the species of lemongrass and its importance in rural areas for generating the employment and enhancing the income of the farmers. So since last 3 years, we are the largest producer and exporter of this lemongrass oil to other countries. Then again, khas, we are going to self-sufficient in khas oil in production. Earlier, we are importing from Haiti and Indonesia. So due to the development and popularization of these varieties, the khas is quite popular. Then we have developed these khas varieties which can be cultivated in waterlogging area, because Gorakhpur is the area which is in catchment of the river. So in Basti, this is the area of Basti. So in Rapti, nearby Rapti, more than 500 acres plantation is available, and this is the area in Brahmaputra River, Assam. So we are popularizing, and these are the area belongs to Kudalur, cyclone affected area. So farmers are cultivating these varieties among the, and our honorable Prime Minister was distributing through online to the farmers of the planting material to the farmers of Kudalur. And in case of this Artemisia annua, so we have developed this anti-malarial drug out of Artemisia annua. We have developed varieties, we have developed technologies, and we have also collaborating with CDRI, and that EMAL injection was developed and transferred to 7 companies, and these companies are exporting EMAL eradicating malaria to South African countries, because it is quite prevalent in South African countries. Sim Sanjeevani, this is again the variety. Ashwagandha. We have developed number of varieties. So these are the Sim Pushti variety having very good Vedonolite. So if we talk about the tonic, then this is our curcuma variety. Then Silymarin, this is the liver tonic. This is we have developed one Sil9 variety for this. Then we have developed the whole genome sequence of the basil, and about 54 lines we are maintaining. And out of 54, we have developed 12 varieties for the farmers and industries. Then Sem Sunahri, this is the asparagus pili satavar. This is the variety of satavar asparagus. Then Sarpagandha, we have developed 3 varieties having very good phytomolecules. Then Phyllanthus amberis. So a non-fatty liver disease, we have developed the phytomolecules for curing the non-fatty liver diseases. Then Sim Spurti, Kavach. We have a number of processing technologies. These technologies can be taken, can be adopted by the farmers. These are the small technologies, big technologies. Okay, then we have very good modern analytical facilities for industry and farmers, especially MSME. We are organizing training programs for students, and most of the students has already visited our institute for their excursion and visits. We are also organizing training programs, awareness program in rural areas. We have every 31st of January, we are organizing this Kisan Mela. So in last Kisan Mela, our Honorable Chief Minister Sri Yogi Adityanath ji was also visited and inaugurated that Mela. Then we have transferred the technologies. When technology is matured, having good efficacy, less toxicity, then we transferred to number of industries for popularization. So based on the medicinal aromatic plants, we have developed number of formulation in skin care, hair care, pain relieving, hand and surfactant, mosquito repellent, health and hygiene, nutraceutical. So these are the some process technologies. These are the technologies ready for. These all are available because time is constant. So we have recently developed some skin protectant from UV exposure. Then therapeutic medicine. We have developed one endographis paniculata based medicine in COVID, and we have having very trials in BHU and DY Patil Medical College, and very good results find because there is no replication in the virus. Then we have developed one this BGR. BGR is having very good success story because we have just discussing with the Sahu sir, because earlier in 2014 we have having very good clinical trial with BHU, and now sir having it only BGR is having more than 200 crores business by Emil. So recently we have developed some mosquito then fennel. This is a fennel based mosquito larvicidal formulation. So we have also developed number of nutraceutical formulations. This is green technology. We have extracted lutein out of marigold. So this is used as a base material for making vitamin A. This is again we are producing eugenol and eugenol rich essential oil and making vanillin, which is vanilla. We are eating vanilla. So we have this incubation facility. After completion of your studies, you can also incubate with these facility and make your own medicine. And we are hand holding, we are supporting this students and startup. So this is the success story of BGR because we have transferred this technology to Emil Pharmaceutical, and now Emil Pharmaceutical is marketing this formulation in India as well as US also, and they are creating about 200 crores of business in 1 year. So because they are giving royalty of 3%, so last year they given 6 crore rupees to CMAP. So that's why. So this is a very good success story. So, and we are also working, we have popularized and we have implemented this utilization of offered flower. Also in Sri Gorakhnath temple, we have given this technology for making incense stick and fragrant cone for making incense stick out of the offered flower. So we are also out of these work we are covering most of the SDG goals because in morning session our honorable VC told that when you are working on your research you have to have focus on SDG goals. So we are covering SDG goals. So thank you very much for giving this time. If you have any quick question, then we can take out your questions. Sir.
Very nice, Professor. Just one comment. Is this the plastic container or because plastic is the cause for cancer? Right? Change it. It's better.
When we are transporting, we are eating good quality or
Thank you.
Thank you so much, sir. I would like to request Dr. Manoranjan Sahu, sir, to felicitate Dr. Ramesh Srivastava, sir. Now, I once again have the honor of inviting Dr. Ranjan, sir, to kindly introduce our next distinguished guest, Dr. Kishore Ramakrishnan, sir.
Now for the third presentation of this post-lunch session, we have with us the honor of having Dr. Kishore Kumar, Head Department of Integrative Medicine, NIMHANS, Bangalore. Dr. Kishore Kumar is a distinguished Ayurvedic physician and researcher with a PhD from NIMHANS, Bangalore, the first Ayurveda postgraduate to earn this distinction there. With over 2 decades of experience, he specializes in integrating Ayurveda with modern neuroscience, focusing on mental health, neurology, and metabolic disorders. He has published 50 research articles and secured significant research funding totaling 15 crores. Dr. Kishore currently leads the Department of Integrative Medicine at National Institute of Mental Health and Neurosciences, Bangalore, and heads the Center of Excellence in Ayush Research, Ministry of Ayush. He has been recognized with the CCRA's Young Scientist Award and represents India in national and international collaborative efforts in Ayurveda education and research. It is an honor to have Sir with us today. May I request Sir to please address the gathering.
Go back.
Very good afternoon. So I've been observing most of you here, second year to final year students, right? So how much of things that happened since morning you were able to comprehend? कुछ समझ में आया कुछ क्या हो रहा है यार? सुबह से बिठा दिया यहाँ पर, बाहर जाएंगे तो प्रिंसिपल पनिशमेंट दे देंगे, है ना? ऐसा कुछ हो रहा है? बात भी नहीं कर सकते, मोबाइल देखेंगे, फिर इधर उधर टीचर्स इधर उधर जा रहे हैं, हमें देख रहे हैं, कल क्लास में पढ़ेगा, है कि नहीं? थोड़ा सर से ऊपर जा रहा है, प्रश्न पूछो बोल रहे हैं तो अरे बताओ यार क्या पूछो, इस तरह से हो रहा है ना? सो आई वाज ट्राइंग टू अंडरस्टैंड, जब हमें बोला गया था और और जब मैंने देखा आपके जो कॉन्फ्रेंस के स्पीकर्स लिस्ट, बहुत हाई प्रोफाइल स्पीकर्स आए हैं. एक्चुअली this is a postgraduate audience seminar or a conference. But then for people who are in the final year, you will be next getting into your post-graduation, isn't it? And that is when you will need all this, because when we were doing BMS, I did my BMS 92 to 97. That was the time when I did. तो हमें बहुत, हमारी हालत खराब थी. लड़कियों को ना पेरेंट्स सोचते थे कि मेरी बेटी डॉक्टर बन गई तो मैं किसी डॉक्टर को शादी करा दूंगा, तो ये होता था. लेकिन लड़कों को ना बहुत मुश्किल, और आयुर्वेद के लड़कियां आयुर्वेद के लड़कों को शादी नहीं करती थी, क्योंकि मालूम है, अरे नहीं, बहुत मुश्किल से शादी किया मैंने खुद. 13 से 14 लड़कियों को मैंने देखा, उसमें 4 थे आयुर्वेद वाले, और सारे आयुर्वेद वाले बोल दिए नहीं. So this was the situation during our time. It has improved. I wouldn't say totally, but still थोड़ा बहुत तो इम्प्रूवमेंट हो गया है. तो लड़कों को थोड़ा सा ध्यान ज्यादा देना चाहिए ऐसे चीजों में, क्योंकि यहाँ पर ना फिर मेरा बेटा डॉक्टर है बोलते हैं ना पिताजी, और कैसा डॉक्टर है तो नहीं पूछेंगे, अच्छा डॉक्टर पढ़ रहा है, बहुत अच्छा. तो फिर आयुर्वेद के जब और ज्यादा डीपर क्वेश्चन पूछेंगे तो प्रॉब्लम होता है. तो उसके बाद रूरल एरियाज में क्लिनिक देखो, कुछ जीपी करो, है कि नहीं. पता नहीं आयुर्वेद में क्या है, देखेंगे बहुत बहुत बड़े बड़े बिल्डिंग्स हैं. सो थिंग्स आर गोइंग फ्रॉम, इट यूज्ड टू बी लाइक दैट. तो हमको पूछते थे कि ऐसा भी कुछ कोर्स है क्या भारत में, बीएएमएस बोलते हैं. तो इस तरह अभी तो लोग जानते हैं कि बीएएमएस कोर्स है कि नहीं. सो दिस आई जस्ट वांटेड टू वेक यू अप फ्रॉम स्लम्बर, and I was trying to look at all of you. Anyway, so this is a transition that is happening in the field of Ayurveda, where you are speaking of integrative medicine. And integrative medicine is, आपको भी पूछते होंगे ना घर में, और रिश्तेदार पूछते होंगे, अरे मुझे बाल बहुत झड़ रहे हैं, कुछ तेल वेल है, या फिर बहुत दिन से घुटनों में दर्द है, नहीं जा रहा है मौसी को, कुछ दे दो, डॉक्टर पढ़ रही है ना तुम्हारी बेटी, है कि नहीं. सो दिस काइंड ऑफ क्वेश्चंस यू नीड टू आंसर, और इधर उधर जाना पड़ता है, यू हैव टू गिव. फाइन. सो देर आर सर्टन, आई थिंक सम स्पीकर्स were just telling us there are some things which we are already taking. Dr. Roy was telling us. So this concept of treatment gaps is emerging, and to fill the treatment gaps जानते हो क्या होता है? Treatment gaps are, आप किसी भी डिसीज को ट्रीट कर रहे हो तो एक सिस्टम से आप इतना ही सॉल्यूशन दे सकते हो, उससे ज्यादा नहीं. अंडरस्टैंड. एंड उससे मतलब एक और डोमेन रहता है जो एड्रेस नहीं हो सकता है. दोज आर नोन एज ट्रीटमेंट गैप्स. लाइक फॉर एग्जांपल rheumatoid arthritis, you can give a painkiller, NSAID, fine, and until you take that, the pain relief is there, but you can't give it for a very long time. So pain management for a long time is a treatment gap. Depression and sleep. When you have depression, there is sleep disturbance. So you can give medicine, and it can so happen that the depression symptoms come down, but then the sleeplessness might remain, for which, and this is known as treatment gap. इस तरह से सारे systems के diseases में you have treatment gaps. ठीक है. एक सिस्टम इसे पूरी तरह एड्रेस नहीं कर पाता है, तब आप दूसरे सिस्टम को जोड़ते हो, और इस तरह से जोड़ना चाहिए कि इन दोनों में इंटरेक्शंस या हार्मफुल इफेक्ट्स या एडवर्स इवेंट्स ना हो. अंडरस्टूड? एंड दिस इज नोन एज इंटीग्रेशन. अदरवाइज जनरली इट इज नोन एज मिक्सोपैथी. आयुर्वेद पढ़ लिया, कहीं जाके क्लिनिक ओपन कर दिया और वहां पे एलोपैथी का प्रैक्टिस कर रहे हो, और कभी कभार आयुर्वेद के मेडिसिन भी दे देते हो. दिस इज व्हाट इज हैपनिंग, और यू गिव बोथ. सो दिस इज नोन एज मिक्सोपैथी. इंटीग्रेशन इज वेयर इन यू ब्रिंग टुगेदर लॉट ऑफ थिंग्स. यहाँ पे बहुत सारे लर्नेड गैलेक्सी ऑफ स्पीकर्स एंड रिसोर्स पर्सन्स हैं, उनको भी थोड़ा सा जस्टिस करना है और आप लोगों से भी बचना है. तो ये दोनों मैं करने की कोशिश करता हूं. So I bring greetings from the premier most institute of national importance in India, the National Institute of Mental Health and Neurosciences. This is the photograph of NIMHANS. It is very popularly known as NIMHANS. In somewhere in 1940s, this is a panoramic view which NIMHANS when it was built. And this is the Maharaja of Mysore, Krishnaraja Odayar. जैसे आप लोगों के भी महाराजा थे, हमारे भी महाराजा थे. तो ये कृष्णराज वडेयार हैं जो मैसूर संस्थान के महाराजा थे, एंड वेरी इंस्ट्रूमेंटल. आप इंडियन इंस्टीट्यूट ऑफ साइंस का नाम सुने हो? इंडियन इंस्टीट्यूट ऑफ साइंस बैंगलोर, जो अभी 2% साइंटिस्टों में आया था. तो देन दिस he was the one who established Indian Institute of Science and many such things in Karnataka. So, and this photograph here is in 1936 when he was laying the foundation of NIMHANS. Maharaja and Sir Diwan Mirza Ismail both were there, and this just historical aspects. This was the visit of Pandit Jawaharlal Nehru ji, Honorable Prime Minister of India, to NIMHANS. And this is something which might interest you. This was the old lunatic asylum of Bangalore. People from Bangalore would know. Anybody from Bangalore? Okay, and this was the next building, and this is from 1950s and 60s. The Panchakarma setup which was there in NIMHANS. Okay, these. Okay, how many of you would want to take up mental health as your postgraduate course? How many? एक भी नहीं. Not even one. Mental health in your PG, Manas Rog. So nobody would want to. Nobody here? बहुत बुरा लगा यार. Anyway, so this was the evolution of the mental health, how it started. 1850, it was known as lunatic asylum. Both the lunatic and asylum were taken away to say mental health or mental illness, and asylum to hospital. So importantly, in 1954, the All India Institute of Mental Health was established. And then the neuroscience was introduced in 1974. It became National Institute of Mental Health and Neurosciences. Just last year, we celebrated the Golden Jubilee as well as of All India Institute of Mental Health and the Platinum Jubilee of NIMHANS. Both we celebrated. So this is just the evolution of. Just wanted to give you the history of NIMHANS. Yeah, so this is the engineering that we are talking about. Throughout my presentation, which I will finish very fast, I just want to highlight upon very few things that you can focus and try to understand. Now, you need not get into all the details. One is that after becoming a professional and then trying to stay in profession, which is a very challenging thing in the Ayurvedic sector, you will have to fulfill certain things. and in integration also, you will have to aim at certain things. Now you have a medical institution that is coming up just adjacent. Fine. Over a period of time, the distance grows. How to close the distance is very important. हमें भी सिखाया जाता था कि हम जैसे फाइनल ईयर में आ जाते थे तो we used to look at allopathic doctors who have finished as दुश्मन्स, मार दो, काट दो. इस तरह से एक मानसिकता डेवलप हो जाती थी. This is, I am speaking of 90s. This is, due to many such reasons. And one of the very important reason is that we never used to communicate with each other. That used to be the problem. So first is enhance communication with each other. Over a period of time, I understood that so many of the modern biomedical practitioners want to know about Ayurveda and want to incorporate. There are so many of them. We have maintained distance between each other, and that is a problem. तो इसीलिए ये डिस्टेंस हो रहा है. तो we'll have to interact with them more and then try to tell them what we do so that they understand. Now, when the science has developed throughout the world, a standardization and uniformity has been a very important thing that is happening. Now you see in a lot of news and social media, or maybe in the things that come up, is that कैंसर के लिए क्यूर. पहले ये होता था ना कि ऐसे सारे चीजों को हम इलाज मिलता है. Successfully this can be cured. So there are so many claims that happen. And because of these claims, people get misled. And because they get misled, there is no regulation. That is known as unregulated sector. Dr. Roy was mentioning about non-codified systems. So there needs to be some standardization. So in modern bioscience, you have a standardized system. Like for example, if you know that you can do something in a particular disease, आपको एक रिसर्च करना चाहिए and इस रिसर्च के रिजल्ट्स को आपको पब्लिश करना चाहिए. And this publication should be in acclaimed indexing platforms. Like Subarna Roy ji बोल रहे थे PubMed, National Library of Medicine, which is a acclaimed. There you have to publish. For that you have to write a manuscript. For that now I also saw some Spark, the students who have just got the research grants through Spark and all that. So you will have to write a design, do the research study, write it as a manuscript, put it. Then they do what is known as peer review. Means they send it to 4 or 5 professionals in the field. They read and they judge whether ये झूठ बोल रहा है या सच में किया है. They will know. They will ask you questions. You have to answer and then they publish. And when you publish, people look at it. Then they call you. They write mails to you. It was very interesting. I want to collaborate with you. इस तरह से चलता है. Fine. In science, it is not that we have anybody can have a separate platform. So if we have to publish in a good platform, the design has to be proper, and that is when you can publish. Okay, and this is a very primary necessity. Now, I was also talking to you about the treatment caps that are mentioning. I'll tell you in brief what we are doing. We follow, currently you have in integrative medicine many models. So the model that we are following is a model wherein an Ayurveda expert, a yoga expert and a psychiatrist, we consult at the same time. This is known as systemic integration and currently being now known as the NIMHANS model of integrative medicine. Morning, Dr. Giridhar was mentioning about certain things of integration. इसका speciality ये है कि physicians, we sit together and optimize the treatment. The patient, of course, has the choice, which is known as cafeteria approach. जैसे होटल में जाओ, मेनू देखो, जो चाहिए बोलो. Fine. So this is known as cafeteria approach. But then integrative approach is where we sit together and optimize the treatment. For example, if there is a patient of depression that comes to us, then all three of us will agree that isko yoga denge bas. Then we prescribe him yoga. 2 months. He is feeling better, fine. If he is not feeling better, then we add some Ayurveda treatment along with yoga. If he is feeling better, fine, after 2 months. Then after 3 months, if he becomes worse, Doctor Sahab, मैं कुछ नहीं कर पा रहा हूँ. Then we withdraw Ayurveda medicines, we withdraw yoga because he cannot do it. We put him on antidepressants or antipsychotics. फिर जाएगा. Then after 2-3 months he settles down, comes back. Then we slowly try and taper out the antidepressants. Introduce Ayurveda and yoga. Slowly withdraw Ayurveda. Then put him on yoga. You got my point? In long-term management, this is working wonders. This is number one. This is what we actually do. And in the process, we try to see if there is any drug interaction. And we are also trying to develop as to how much time it is taking for patient to respond. So this, we are, experiencing very good results. And apart from that, we are now handling, अभी very commonly asked question is schizophrenia. इसके लिए आप आयुर्वेद में ट्रीटमेंट दे सकते हो क्या? I agree that we do not have medicines that can handle psychosis on an acute basis, but there are so many other treatment gaps that we can handle, and that is what we are doing. And one of the things that we have now achieved is treatment emergent complications. Antipsychotics पर रहते हैं. Antipsychotics बहुत ज़्यादा दिन लेने से metabolic syndrome हो जाता है, diabetes, cardiovascular disease, etc. And then the patient has to be functional. For example, women, they go into amenorrhea, their fertility level goes away. Now we just add on Ayurveda and we have seen that the fertility level comes back. The patient is functional, is taking antipsychotic, is going to work and is able to raise a family if she wants. This is something which we have achieved. Weight gain, हमने देखा है कि weight gain में plateau तक आ गए हैं. Plateau से कुछ लोगों को तो weight कम भी कर पा रहे हैं हम लोग along with that, and it's a very big problem in antipsychotic associated weight gain. These are treatment emergent complications. Negative symptoms of schizophrenia. Schizophrenia you might have heard, and there is something known as negative symptoms and positive symptoms. Schizophrenia is I think most of us know. So you have positive symptoms is where the patient is violent, aggressive and so on. And negative symptom is totally socially withdrawn. And that is when we give some things. So the response of such patients to antipsychotics is very less. And we have seen that with Ayurveda and Yoga, they have responded very, very well. So these are 4-5 areas where we have evolved. I'm just telling you my experience. It was not that we just searched that. But then when we went into NIMHANS, people started looking at us like aliens. अरे यार ये क्यों यहाँ है? अरे भगो इसको. This was how we were seen at, and now we are being seen better. Initially they started sending us antipsychotic induced constipation. अरे भेजो यार इनको constipation के लिए कुछ आयुर्वेद में वो खाइम चूर्ण वगैरह देते हैं ना, देखो तो इस तरह से they started sending us, and now we are getting referrals for solid negative symptoms and many other serious things. So this is my experience. I just quickly run. This is the approaches that I was talking about. Some of the things that we have published. So our job is not to become only another mental health Ayurveda hospital. Our job is to generate evidence, because only when you generate evidence, you are able to talk to people about what integration is. And pushte hai na. So in NIMHANS, if I am treating something, so they won't send us patient simply. We will have to demonstrate. This is what we published as a perspective of integrative medicine in the beginning. Then this was what we talked in the morning. There was discussions on one nation, one health, the Prime Minister's vision. And this was how integration, implementation, the strategies that we mentioned, wherein yoga can be used as the first approach because it is non-pharmacological, acceptance is much more, and then people start getting interest, and then you can add on more and more systems of medicine. So this was another publication where we talked about mental health and how in the community it is present, and we suggested that this was published in Lancet Psychiatry, and this is where we talked about mental health community of practice, where how we can get together. See, what we are talking of integrative medicine is inclusive medicine. So it was like in NIMHANS, people used to come, वहाँ मंदिर गए थे, वहाँ चर्च गए थे, etc. वहाँ मत जाओ, वहाँ जाओगे तो आप you people will be doomed. इस तरह का होता था. तो people बोलना बंद कर दिए, क्योंकि लोग मंदिर या मस्जिद या चर्च या कहीं भी रिलीजियस सॉल्यूशंस मिलता है ना, वहां जाते ही हैं. आप उनको जो भी बोलो, because that has been traditionally there. So people stopped telling us that we were going to the psychiatrist. Now we said that okay, let us see what is happening. We try to correct them. So like this, so we have talked about how the psychiatry management or traditional psychiatry has been there, and you will be surprised, our Indian traditional way of managing psychiatric disorders is also present in many of the ethnic countries, like African countries, Ethiopia, okay, and many such republics. They have the same kind of management and cultural orientation like how Indians have. This was the first publication that we did on depression in mild to moderate, Ayurveda as a standalone treatment. We also compared the Ayurveda treatment with the tricyclic antidepressants and SSRI, selective serotonin reuptake inhibitors, to see how they managed. हो गया. And then this was about the in general anxiety disorder. And this is negative symptoms I was talking about. And after this publication, we started getting good referrals to our OPD from our own colleagues. And this is on ADHD that the current trial is going on. And this is I was talking about metabolic syndrome treatment, emergent complications with antipsychotics. And this was the manuscript is ready. It is to be published. In negative symptoms, Virechana and Vamana have done very encouraging results. Similarly, in integrating Ayurveda into depression management with Virechana. Yoga, we have had very good publications. In schizophrenia especially, we have had standalone as well as add-on. Yoga and depression, in substance use. And this is Om chanting and yoga. We have seen limbic deactivation, and we have also seen certain areas of the brain that gets activated and certain areas of the brain that gets inhibited. This is very important in refinement of brain functions, and that is enhanced by Om chanting as well as yoga. And this is the yoga related neurotropic effects, the increase in gray matter that we have seen. Neurosciences, yes, in ischemic stroke, in ataxia, in spinocerebellar ataxia, in tardive dyskinesia, in GB syndrome. And this is our study on Duchenne muscular dystrophy. What we have seen is the ambulatory phase we can continue in children. That is how the course of illness, and this is the course of illness where the ambulatory phase can be continued. This is still an unpublished study. This is a rat model of Alzheimer's disease. Beta amyloid plaques. The first one is with Brahmi. The second one is with Mandukaparni, treated for 14 days. You can see the effect of Brahmi and Mandukaparni in the dentate gyrus of the rat brain, which was administered with Brahmi and Mandukaparni for 14 days, and this is the result that we got. Anyway, some mechanistics and so on. Yeah, these are some of the things that was very importantly seen as problems and associated factors, things to be addressed with integration. So a patient is not more or less incidental container of an interesting biochemical, physiological or bacteriological situation, but is something far more. A clinical picture is not a mere photograph of a man sick in bed. It is an impressionistic painting of a patient surrounded by his home, his work, his relations, his friends, his joys, his sorrows, hopes, and fears. A doctor is not treating a disease, is not treating a mere case, but a human being in whom the importance of psychology is over 90% and of physiological pathology is less than 10%. You understood? You are treating the person's mind more, 90% is the patient's mind. You are not just treating an organism of pathophysiology, is what he said. This was Dr. M.V. Govind Swami, former director of NIMHANS, very popular statement. Dr. D. Nagaraj and Dr. B. N. Gangadhar, who were responsible for the establishment of the Department of Integrative Medicine. Thank you so much. You have anything to ask me, please?
It's a very interesting presentation. For people like us, I'm a psychologist, unfortunately, but people like us, Lehman is like a buck up front. But what is interesting here in your presentation, if you can look at the HRV, heart rate variability, and there is a lot of work that has been done by Dr. Roger Callahan on HRV and thought field therapy. We also understand that there is a vagus nerve and biofeedback if we can work together. So basically the approach, what you have at the moment, I think we can make it more clinical. And if you use a lot of other technologies which we are getting these days. But a wonderful work, sir.
Thank you so much.
And there is a major problem what we are going to face in India. If you're not interested in mental health is going to be a major problem in India by 2025, 2030 or 35. So in Ayurveda, you have a potential to use your expertise if you understand God good Vidya in totality and understand Bhautik and Abhautik and many other things which are also a combination of spirituality. So it's a wonderful thing, sir, what you're doing.
Thank you so much. क्वेश्चंस पूछो मुझे मेरे से कुछ पूछने के लिए ना 15 दिन लगते हैं अपॉइंटमेंट के लिए निमैंस में अभी पूछ लो
Dr. Chetali, wonderful talk. There is a drug called Largactil, which
called
Largactil.
Largactil, yeah.
Yes, I understand it's derived originally from an Ayurveda herb. Is that correct? Might you comment?
Yes. I have known about this, but then I'm so sorry. I have not done much of homework to find out which herb it was. But then I will get back to you.
I would like to one thing I would like to suggest you.
Thank you.
Because in Ayurveda, in Charak Samhita, Chikitsa Sthan, 4 drugs are described for as a mental boosting drugs. Manduk, Parni, Swarasa Priyojya, Chiren, Yasti, Madhukasya Churnam, Grase, Guluchya, Samul, Puspa, Kalka Priyojya, Khalusanga Puspi.
Yes.
Medhyani, Chetani, Rasnani, Medhyab Visesena Chansanga Puspi.
Yes.
You have compared the results of the Brahmi and this Manduk Parni.
Yes, sir.
Sangha Puspi is supposed to be one of the best drug for the mental ailments.
Yes, sir.
So the trial to the Sangha Puspi must be done.
Is going on. Is going on. Thank you.
About the home chanting for different activation. Sir, a lot of methods are described for home chanting. So which methods are you used for home chanting in the activation of the?
It was a yogic. We have a yoga team in our institute. It was a Om chanting, which they generally do as 1:2 ratio O comes 1 and is around 2 times of ratio. So there's a method in which they are trained and the patients chant. It's a simple Om chanting. Good. One student. You're a student? Good.
Hello. Yeah, Namaste, sir. Your presentation was amazing. I have a query regarding Kuti Praveshika Rasayana. So here we treat the patient with Rasayana Chikitsa in a confined area. That on parallel level, I want to compare with an astronaut's life. Again, even they are in a confined place. So why is that so that Koti Praveshika is taken as treating a person, but at the same time, again, this is a confined area, but astronauts are prone to having neurodegenerative disorders and stress and anxiety related issues. It could be because of traveling as well, but my basic concern is, does confinement affects a mental health of a patient?
Absolutely. The confinement is known as restraint stress. It has been proven, established that when you restrain a person, the neurons as a whole, the volume of neurons, they decrease. And they go into many other, depression and so on. A lot of animal experiments as well as, human studies have proven this. So when you confine someone, it leads to stress, it leads to loss of neurons. It is true. Kuti Praveshika Rasayana, I'm not very sure because I don't have any experience, nor have I seen any center practically going there and looking at how they are doing. It's not a very widely, practiced kind of a treatment. But then I've heard that there is a certain period of, even if you think of Vipassana meditation, that's also a kind of meditation where you have to block yourself. But then there might be a certain period of time after which the neurodegeneration starts. So in that particular time, and then even before doing Vipassana also, they tell us to do a lot of preparatory things to follow. So yeah, confinement as such, it might be related to the time, but then it is certainly a restraint stress and leads to neurodegeneration.
Currently, my presentation's focus is on astronauts' health. So with respect to that, I want to ask, how can we make it better for them at a psychological level?
That's a very good sort of idea. Put it on paper, produce a research title and go ahead. You can maybe do something like this and give it to the astronauts and tell them after a few days that you were able to prevent. Wonderful idea. Please do it. Yeah.
Don't like to take drugs or follow on. So sometimes in historical patient or in mental patient, they get unconscious or hysteria. So is there some emergency drug or injectable in Ayurveda by which we are lacking this for the emergency patients?
No, sir. We don't have. I'll tell you in very brief why it is not there. The Ayurveda treatment, Dr. Tomar has been, time and again, trying to give his opinions on the basic principles of Ayurvedic. Now, for example, you have a herb, and this particular herb has so many phytoconstituents. And we have seen that, let's say, currently we are doing a study on Jatamamsi. That's a Himalayan herb. So there are more than 35 phytoconstituents in Jatamamsi. And what we have seen is, as Sir was saying, that the Jatamamsi, if it is grown in south, it doesn't work. Only if it is grown in the Himalayan plateau, it works better. That's number one. And northeastern. And then there are some agonistic and antagonistic phytoconstituents that you might have heard of. Sir was also telling about reserpine from Sarpagandha.
आप रिसर्पिन को आइसोलेट कीजिए और उसे थेरेपेटिकली यूज कीजिए, आपको बहुत सारे साइड इफेक्ट्स आएंगे। मतलब उसके लिए उसको हैंडल करने का भी कुछ तरीका है, लेकिन साइड इफेक्ट्स बहुत ज्यादा है। एंड इफ यू यूज सर्पगंधा एज अ होल, साइड इफेक्ट्स नहीं है। तो बेसिकली व्हेन यू आर यूजिंग द आयुर्वेदा हर्ब और अ पॉली हर्ब, then you are using it as a whole. If I isolate a phytoconstituent, then it is possible for me to look at a targeted pathway, and then that's how that phytoconstituent can get into an injectable. But when you are giving it as a whole, then we are looking at, maybe CMAP can take up this, because we have had some discussions with the CDRI Lucknow and the CMAP also before, quite before. क्या आप, for example, एक formulation है दशमूलारिष्ट, जिसमें बहुत सारे हर्ब्स हैं और एक हर्ब में 25 से ज्यादा फाइटोकॉन्स्टिट्यूएंट्स हैं, तो आप 40-50 हर्ब्स और उसके अंदर इतने सारे फाइटोकॉन्स्टिट्यूएंट्स, सो यू आर लुकिंग एट अ ओशन ऑफ फाइटोकॉन्स्टिट्यूएंट्स। क्या हम उसमें जो एक्टिव हैं इसको आइडेंटिफाई कर सकते हैं और इन सारे चीजों को एक कैप्सूल में आ सकते हैं? दिस माइट बी अ नेक्स्ट जनरेशन रिसर्च दैट माइट हैपन। आई टेल यू व्हाई इट इज इंपॉर्टेंट। दशमूल में 3 से 4 हर्ब्स हैं जो ऑथेंटिकली यूज हो रहा है, बाकी नहीं मिल रहे हैं और बहुत सारे एक्सटिंक्ट हो चुके हैं। डॉक्टर रॉय भी बोल रहे थे कि रेगुलेटरी एस्पेक्ट्स नहीं है, फार्मर्स को जो कनेक्ट करने के एफर्ट्स सीमैप वाले कर रहे हैं, ये एफर्ट्स अभी काफी नहीं है। बहुत सारे चीजों को जो वाइल्ड से, फॉरेस्ट से निकाला जाता है और वहां वो एक्सटिंक्ट हो रहा है। It has to be immediately stopped, and farmers need to be encouraged to grow, and they have to be connected to the pharmaceutical industries, which they are doing. और इसका importance बहुत ज्यादा है, इसको recognize नहीं किया जा रहा है। So that is the things which are there. हमने एक कर्नाटक में एक फॉरेस्ट डिपार्टमेंट वाले, इसको हालांकि मैं I should not tell it because this didn't take off and it felt with it faced a lot of resistance. तो एक फॉरेस्ट ऑफिसर थे, so he initiated a project which was known as bioresources. तो इन्होंने क्या किया, सारे आयुर्वेद के फार्मास्यूटिकल वालों को बुलाया और पूछा कि आप अपने जो रॉ मटेरियल्स हैं कहां से प्रोक्यूर करते हो, इनका लिस्ट दो। नेक्स्ट मीटिंग के बाद वो आए ही नहीं, nobody turned up. उनको फोन किया गया, उनको लेटर्स लिखे, उनके लॉट ऑफ थिंग्स हैपेंड। देन जो फॉरेस्ट ऑफिसर थे उन्होंने कहा कि आई विल गिव अ समन्स टू देम। यहां तक गया था, लेकिन वो कंट्रोवर्शियल हो जाएगा इसलिए रुक गया। बट देन इफ यू आस्क द इंडस्ट्री दैट आप अपने हर्बल रिसोर्सेस कहां से लेके आ रहे हैं, ट्राइबल्स को पैसे दे देते हैं या शराब कुछ दे देते हैं, वो जाके लेके आ जाते हैं, बिकॉज ट्राइबल्स कैन गेट इनटू द फॉरेस्ट एंड दिस इज बीइंग मिसयूज्ड। सो इट्स अ लॉट ऑफ ग्रे एरिया इन दिस थिंग। द बेस्ट वे टू डू इज व्हाट सीमैप इज डूइंग।
थैंक यू सर, मार्वेलस प्रेजेंटेशन। एक थोड़ी सी बात एक बताना चाहूंगा बच्चों को, स्टूडेंट्स हैं, कि हम लोग जब शुरू में दवा लिखते थे एलोपैथ का, कोई पूछता क्या खाएगा, सब खाओ। फिर अमेरिका से रिसर्च आया कि फॉर हिपेटो रीनल प्रोटेक्शन आप जो है हफ्ते में 1 या 2 दिन व्रत रखो। तो हमने कहा वो तो हमारे पहले से है, या आप महीने में 4 से 6 दिन या साल में 1 महीने। तो ये सब चीजें अपने तमाम व्रत है, नवनाता है, तमाम व्रत रखे गए। फिर कुछ दिन बाद ये आ गया कि नहीं, आप जो है भोजन भी बचा खाना है और साथ में दवा खाना है। एलोपैथ में हमारे आ गया, जब मैं केजीएमसी पढ़ता था रिसर्च आते रहा। फिर उसके बाद ये आ गया कुछ दिन बाद, नहीं भोजन को आप दवा खाइए। अमेरिका की रिसर्च बता रहा हूँ, भोजन भी आप दवा की तरह खाइए। तो हम, मेरे बच्चों को कहने का मतलब ये था कि वी आर ग्रेजुअली, आप एक समुंदर हो और हमारे एलोपैथ एक नदी है जो धीरे धीरे बहते बहते फिर आपको समुद्र मिलेगी। इसलिए यू आर ग्रेट, और इसको ग्रेट फील करते हुए आप उसको जो है ये सब चीजें। थैंक यू सर।
Thank you so much, sir. Now I would like to request Dr. Manoranjan Sahu, sir, to felicitate Dr. Kishore Ramakrishnan, sir. हाँ। Once again, I would like to invite Dr. Manoranjan Sahu sir to share his esteemed observations and discerning thoughts on the enlightening session that just took place.
I feel we are running short of time probably. The session was wonderful. You said there are excellent speaker with us, and I'm sure all of you have enjoyed the session. And there are a lot of interactions which you have done by audience. So thank you for giving me an opportunity to session this very wonderful chair the session. Thank you very much, the organizers, for giving me an opportunity. Thank you.
Now, I would like to request Dr. Arpit Walia sir to felicitate chair and co-chairperson. Last but not the least, I would request Dr. Ranjan sir to felicitate the coordinator for the session, Dr. Arpit Walia sir. Now, I would request Dr. Ranjan sir to felicitate the anchor. Now, I would request Dr. Ranjan sir to felicitate the reporter. Now we'll have a tea break and we'll be back by 4:45.